next clinical update is from Wayne Varndell. And again, you all know Wayne, clinical nurse consultant extraordinaire at Prince of Wales and New South Wales branch president of the College of Emergency Nursing Australasia. That's fine, he told me. He has done so much more, then that's fine. I just love the end. I'm trying to aim for this. He has received over $900,000 in research and project funding. Well done, Wayne. Thank you. I'll hand you over to Wayne now, who'll talk to you about procedural sedation.
Thank you, everyone. What normally happens when I present this topic is one of two things. Everyone decides it's the appropriate time for a toilet break to check your Facebook status, or people just randomly fall asleep. So what I'm going to present to you is real-life sedation in ED, and some of the things that you might be able to take away with you today and move from your heads to your feet and make a difference tomorrow. So I've come from a variety of places where the role and the value and the skills required of an emergency nurse are varied. And I think my colleagues from Prince of Wales educators would appreciate this, and I think every educator. When you have nurses from overseas, they come with different skills, capacities. They also have unique assistance. In America, you would not be titrating a ventilator on a patient. You would have a respiratory technician or a ventilator technician. You would also, in Germany, for example, it would be the anaesthetist and the surgeon that would have absolute control of the mechanically ventilated patient, plus or minus trauma. In England, it's an anaesthetist-led sedation type thing. And ED physicians get to play with the procedural stuff. We get to sort of play with the make it comfortable for a while, pull, click, you're all better now, off you go. The best place is South Africa. Who is from South Africa today? Anybody here? Yay, thank you. Nurses do everything. Yeah, literally. If you have a pulse, you're the nurse's problem, and we will solve you by putting tubes in every orifice. But come to Australia, and there is an interesting contention about controlling pain and sedation for patients. It's the nurse again. And we spend lots of time training emergency nurses to have the best knowledge and skill sets to optimize pain relief and sedation quality in these patients. But it is under-recognized. It's largely an invisible caseload, and it's a huge work for your educators. So please do appreciate every moment of time you have with them. So, here's an alternate fact for you. A straw poll of emergency physicians actually thought we were doing very okay with sedation and pain relief in EDs. And why? Because I'm not called as often to the patient's bedside to solve a problem that nurses have detected. There is no evidence around how good we are doing in this area of procedural sedation or continuing sedation, but there are horror stories. So your classic ED patient should have the perfect departure angle. They should have the appropriate triage category. They should receive all their interventions in a timely fashion, seats back, tables, headrest, video on, and we've managed to avoid the 4-hour target warning, and we're plain sailing for an admission within 4 hours. Does that happen often? No. This is what happens. If you are lucky, no, I did this, and I must admit, I have to absolutely apologize, and you will absolutely realize this. I did this after the Malaysia airline disaster. This was not appreciated. Anyway, we are sometime beyond that. But just imagine this is your healthcare system plus or minus ED. And we don't get patients with predictable trajectories that often. And who has had Murphy's Law bite them in the arse? You have transferred a patient magically at 3 hours, 59 minutes and 59 seconds to your ward, and they've called down to say their blood pressure's just crashed, we're pacing, and we're just going to report you for not resuscitating this patient appropriately. Murphy's Law will get you in trouble all the time. And why is this? Because this is what's happening in resus. I'm not going to talk about how you inflate that thing, but I'm sure you know from the video how that happens. But you have individuals, and I'm not bagging people out, resuses are scary. For people without the knowledge, skills, expertise, exposure, it is scary. And there's more than just a nurse in that environment that has to learn how to work with these patients. You will have junior medical colleagues who will be facing a broad variety of issues that will also be equally challenged in managing these patients. So please don't forget that they're also important. But often what is happening, just as you can see here, we're on the tannoy calling for assistance. Now, when you're under pressure, I don't know if you realize this, apart from checking your Facebook status, tweeting or Snapchatting a disaster and thinking about coffee, you're more likely to turn to a colleague and say, what do we do here? You know, what buttons should I push? How should I do this? Or you're picking up the tannoy and calling for the doctor or some assistance in resus. In most of the resus departments that I visited for some periods of my research, they're behind closed doors with no windows in. You are in a locked box. And even more so, you might have a dividing wall between your resus bay and the next one to it. So technically, you are in that creepy cabin with a patient who's just woken up, that's received a different amount of sedation. I think this person's obviously received, intrajugular or interocular droperidol and it's decided to spring up. And now this patient is presenting problems. Do you have space for one more? So now, with the critically ill patient that you're trying to depart vertically upwards and not 6 foot down, you have someone who has just arisen from the grave and someone who's practicing their rock climbing skills. So nurses are confronted on multiple fronts when trying to deliver quality care. We could be here and be talking about any subject with any population in ED. We're just challenged left, right and centre. So how are we doing? So we looked, and this is an update, we looked at the evidence. There's little evidence regarding the safety of procedural sedation or opiate-based sedation in ED. There's virtually none. Pediatric communities, yes. Why? Who wants to deal with a child screaming in pain? You want to give it drugs in the nicest way because the parents will hit you if they see you hurting your child. So intraocular, thump, works. It actually works very well with the geriatric patients as well. It's least confronting. But there's very little in adult land. So that's a mindful of playroom. You can play in that space, but there's very little. We poorly manage sedation for critically ill patients, and we know this because there's an increased mortality when we get it wrong. Now, you have that variable, fluctuating, physiological reserve capacity type patient that you're adding aliquots of drugs, which we know impacts on preload and cardiac output. So you are playing Russian roulette. You know what's in the syringe, but you don't know how your patient's going to respond. And that mortality does not change from ED to ICU and vice versa. We know that pain increases the sympathetic tone, and as we've just heard from the hemorrhage lecture, that can make things a lot worse. It actually pushes coagulopathy even harder with the stress response. So we know pain is really important. It's not just for allowing you to get back to your iPhone. Dislodging invasive devices. How many people have actually had cannulas being ripped out in their patients when they've been agitated due to pain? If you give your patients lots of analgesia, you don't need to give them much sedation because they're under a barrage of pain. And we've had patients self-extubate. We've also had patients physically assault and abuse those nearest to them, and that is often the nurse. So aggression is one of those areas, and I know EDs are predominantly talked and discussed about being sort of co-black, high violence and aggression areas, but the other one is recovery. When patients start experiencing lighter levels of sedation, they're ready for fisticuffs straight off. Access block, we could talk about forever what this thing makes everything. It just makes everything worse. There's a 1.5 increase in mortality per year in delayed transit of patients. And if you then add on the need to adequately sedate and control your patient in mechanical ventilation land, not just the relocation shoulder and hip, knee and joint land, this becomes a minefield. And I've got another slide which I'll just put up, and it's a meme that I want you to take away with you. It's a little grain of truth about this one. There was a SPICE trial that actually did start to look into this area and actually found that what ED nurses want, we want you flat, still, tube in every orifice, don't even budge, I'm drinking my coffee. ICU, we want you kicking, flopping, breathing, interacting and responding. Two different worlds. I like it, ED. But they found that we were more likely to over-sedate, nigh on general anesthesia, which doubles your mortality. So if you come in as a trauma patient and you don't get your quick clot and your tranexamic acid and you don't get a trauma response and you get all the wrong things going, and then we just super sedate you, makes it better, well, there's only one destination for you. Okay. Over 70% of patients intubated and ventilated recall active, severe pain. And we found this in cardiothoracic patients in ICU, and we're finding them in ED too. We when we paralyze a patient, anyone know how, on average, how long succinylcholine works in the body for? Shout a number out if you know. About 3 to 6 minutes, okay. Roxaronium, it's the new thing to rock your patient to sleep. How long does that last for? About 60 minutes, doesn't it? Yeah. So when we actually looked, the button to push analgesia was turned on when the patient moved. So how long would a patient be waiting for analgesia if they'd been rocked to sleep? So we've had to do a lot of work in this space as part of your safe, rapid sequence introduction sequence that's perfectly needed to put on there, discuss sedation analgesia up front. Have it loaded and ready to go. Don't wait for your patient to flinch, move, and start pulling out lines. Let's start some baseline analgesia and sedation and titrate to the patient's needs using valid, credible tools. And there are many. And if anyone dare mentions 10 out of 10 or the numerical scale, come see me afterwards, okay? Because it is absolutely inadequate to use with the intubated, mechanically ventilated patient. They're not going to hold up numbers and tell you how much pain they are in, okay? Emergency nurses are actually in this space. We are the ones who are predominantly, due to our co-location, our dedication, our focus, our role in monitoring and detecting deterioration, you're the guys in charge. I wonder how many of you just push that up button. Just touch it. And then tell someone you did it. Don't tell me, okay? Don't tell me, but I'm sure you do. Because we recognize pain. But one of the studies that we did, and we asked nurses, and this is the meme for you to take away today. We asked people, so what kind of happens after you've intubated and mechanically ventilated your patient? This happens. You turn around, and everyone else, apart from the cleaner, has left. They put the tube in, they've given you drug orders, but you can't vary the drug order, it just says 1 milligram of prop an hour. And now you've got this person who is either, because of vasovagal stimulation, crying, coughing, spluttering, waking up if they've had sucks 3 minutes ago, and that sounds like a party that you would really want to leave at, but your backup has just left. We've got some fantastic quotes from nurses. It's like, once the tubes are in, they've gone. You have to ask them everything before they go away. And then we ask, who's best? ICU are best. Because they know what happens when you poorly control pain. There's a 60% chance of you developing chronic pain. There is a 15% of a chance of you developing PTSD related to poorly controlled pain and sedation. They deal with the back end. So we have a lot of lessons to take from this. And as I said, in my thesis, I tried to call this theme, because we all love qualitative research, don't we? I tried to call it abracadabra, but my dedicated supervisor, Margaret, at the back went, they won't get it. Yes, they do. We all know what happens. So I thought, following on, I don't have a witty acronym like spew, puke, vomit, or any of those things that Ian put forward the other day. I went back to roots, ABCDE. That just seems very simple to carry with you. And you would obviously vary this depending on the type of patient you have in relation to sedation and pain. And you've got this magical word called analgosedation. It means put the pain relief with the comfort enhancer. Put it together. Don't have it just keep giving them sedation. Because what's actually happening at the bedside is doctors and nurses are treating behavior, but they're not treating the cause. So A, ask about pain. Now, you can ask patients' relatives. Actual fact, national guidelines recommend if you don't have a valid tool, there's only 2 that you can choose from by a literature review that was done recently, ask the relatives. How do they display their pain? If this is a dementia patient, a patient from a nursing home, a patient that people have spent years caring for, ask the next of kin. Assess pain systematically with the appropriate tool. Look for probable sources. The tube hanging out of their mouth might be one of those. The fact that you're going to roll this patient to do a survey onto an open book pelvis fracture, how about you give them some pain relief just a little bit beforehand? You do that. Believe the patient and the family in their reports of pain. I know, it's so easy that, and this is my great litmus test. Who's seen a meme about 10 out of 10 pain? It's often someone with their tib and fib snapped in two. That's 10 out of 10 pain. In actual fact, it can be so subtle. If you're unable to communicate due to cognitive impairment, toxicity, you could miss it entirely. Unless, I think, absolutely truthfully, you have actually been in 10 out of 10 pain. We all carry an individual level. Mine with 3 children is stepping on Lego. To the point now, my son has learned if he scatters Lego, it's a bit like salt and witches. You can't get to him. He knows you're not going to go stepping on that Lego to get to him. C, choose appropriate pain control options that are relevant to your patient's needs and the setting. Obviously, you don't want to promote cardiac failure whilst you're just whacking in the morphine, although in little bits, it's very good. Deliver analgesia and sedation in a timely fashion. Don't wait. This is not the after-party gig. This is something you have lined up. Because after you've managed to intubate safely your patient, you've realised all the numbers are evening out. There's an X-ray to do, there's a CT to do, there's a portal to sort out, there's a ventilator problem kicking off. Some 3 people in your next shift are just called in sick, and I don't believe it's done properly. You've got to fill out the fluid balance chart because the next person coming on is being supervised by an educator. You ain't going to have time to get your syringe out and start doing all this. So delegate someone to do this, and they get the job done. And talk to the prescribers, and there is nurse prescribing coming along with this, but get them to allow the authority to titrate. Prescribing fixed doses is torture. Most 75-kilo gentlemen are going to need more than 5 milligrams of prop an hour. They're going to be in double digits. And if you've worked in other areas, you're going to need more than that. Evaluate regularly, and if the patient is able to respond and partake in designing their pain management plan, tell them it's okay to tell me you're in pain. We did a study looking at triage, and the triage nurse just said to a random 50 people, the sentence, if you're in pain, please tell the nurse looking after you. Do you know what they did? And they got better pain relief. And they reported better care. It matters to tell people what they're able to say to us. Please don't ignore the subtleties. So here's the gold standard. Plan your sedation and analgesia earlier. Use and communicate with emergency staff early on in this program of rapid sequence intubation and procedural sedation. Every intubated patient should have analgesia and sedation titrated to their needs. Use valid objective pain scores. I've got pictures of CPOT and RASS. If you don't know what they are, look in the AE&J. There's a detailed systematic literature review there for you. Prescribe the ability to titrate meds. We found covert titration when we interviewed emergency nurses. Nurses know when their patients are in pain. They know the solution. They know when to improve sedation. And it's about time we had that prescription altered in some way, shape or fashion that actually made that whole thing valid and legal. First-line agents, non-benzodiazepines, ketamine, prop, associated with better outcomes. It does depend, obviously, in the context and the setting that you're using them in. Love your ketamine, but be a mixologist. Put the gin with a tonic when they need a bit of either. Don't just load it in one syringe and believe it is the panacea of everything, because it's not. You do need to separately titrate these things, and you'll probably find, as literature demonstrates, the more analgesia you give, the less sedation they need, and the less cardiopulmonary impact that will have for your patient. No sedative, of course, or analgesic is completely safe, even though we have very little evidence in this field, because all patients respond differently. And you, as the emergency nurse, are optimally placed to detect and intervene in this area. You have so much more to give. Just had to get that one in. Alternate facts. Okay, remember that. These are CPOT and RASS flowcharts, which you can get from various places. There's one that's actually in the A&J, but also a few other journals. I forgot to put the reference on. But you need some way of discussing. And what we found when you use tools, clinicians listen to you. When you use tools in your communication, they can understand the problem that's emerging, and you can better quantify your response. Please always give analgesia first and explore for other causes. I'm not going to talk today about delirium in this sort of mix, but get some tools into your department because it really will help you target and titrate. Thank you very much.
Thank you, Wayne. Some great food for thought there. Any questions?
Here they go to the toilet again.
Yeah.
We're just about to talk about drugs.
Yes.
Good, I've escaped. Thank you very much.
Okay, thank you, Wayne.